Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be talking on one of the another topic which you will see good number of time in your everyday practice. We call deep vein thrombosis. Now this venous thrombosis is quite common and it can end up with a dangerous complication we call as pulmonary embolism. Then we call as a venous thromboembolism. So we'll be talking on two parts, deep vein thrombosis, which can end up into thromboembolism. Deep vein thrombosis is a formation of a blood clot in one of the deep vein of body. The most common vein which is being involved is a deep venous system of lower limb. But if there is an inflammation, then we call it a thrombophlebitis. So if there is a formation of thrombus with inflammation, then we call that as thrombophlebitis. And usually thrombophlebitis is always of superficial vein. And it is very common after venous puncture. Phlebothrombosis is thrombus formation with minimal inflammation. And thromboembolism is dislodgement and migration of a thrombus, part of a thrombus, into distal. That is called thromboembolism. And if it is from phlebothrombosis, then it is inflammatory material which can be there. The most common, it is a lower limb, and then it can end up with what we call as a varicose vein also. This is venous thrombosis, usually in a deep vein. So the circulation of perforated veins and superficial vein will be affected and they will become dilated and tortuous. We'll call that as varicose vein. Deep vein thrombosis, most commonly lower limb, usually will begin in a calf muscle deep vein and it will propagate proximally to the popliteal vein, femoral vein and then to iliac veins. Deep vein thrombosis in lower limb is about 10 times more common than upper limb. And in upper limb, it is commonly precipitated by placement of the pacemaker, cardiac cath, internal cardiac defibrillators, wires, indwelling central venous catheters, etc. Superficial venous thrombosis is usually present with erythema, tenderness and palpable cord-like structure. And that can extend to thrombosis to deep venous system also. We can classify venous thrombosis into deep vein and superficial vein, upper limb, lower limb, superior vena cava, inferior vena cava, and very odd cerebral venous thrombosis, particularly maybe involving superior sagittal sinus and its connections. In lower extremity, it is most commonly the calf muscles. It may involve pelvic vein, renal vein, inferior vena cava, ovarian vein. In upper extremity, it can involve upper extremity, subclavian, and even the neck veins. So all this portion can be involved. If we go to the etiology, we call it a Witchoff's triad. That is because of venous stasis, classical example, atrial fibrillation, obesity, immobility, pregnancy, etc. We'll be going through some other causes also. And endothelial damage because of trauma, external pressure, IV caustic substance or we call IV fluids or IV injections, what is going to produce endothelial damage. And there are some hypercoagulable stage like polycythemia, severe anemia, certain malignancy, sepsis, oral contraceptive pills, smoking, and others. As we have told you that deep vein thrombosis very commonly starts in lower extremities, mainly calf muscle, and then progress proximally to involve popliteal, femoral, iliac system, and may end up almost in 80 to 90% into pulmonary embolism. The second word which is utilized is phlebothrombosis, which is acute, which involves deep venous system, and usually it starts with calf vein. From that, it may break up and give rise to pulmonary embolism. It is said that pulmonary embolism, out of 100, 80 to 90% of the time, it is from deep venous system. We already mentioned the three groups: stasis, endothelial injury, hypercoagulation. In hypercoagulability, major surgery, trauma, malignancy, pregnancy, particularly postpartum period, inherited thrombophilia, infections, sepsis, IBD, autoimmune conditions, oral contraceptive pills, inflammation, dehydration, etc. All these causes will give rise to hypercoagulation. Stasis, most common cause, immobility, venous obstruction like obesity, tumor, pregnancy, varicose vein, atrial fibrillation or left ventricular dysfunction, congenital anomalies, and low birth rate also. Bradycardia and hypotension. As far as the vascular damage is concerned, cellulitis, thrombophlebitis, indwelling catheters, particularly pacemaker wires, central venous catheters, heart valves. Venipuncture becomes the most common cause for thrombophlebitis, trauma, strain, injury, microtrauma, etc. So, in hypercoagulate stage, malignancy, pregnancy, oral contraceptive pills, trauma, surgery, inflammatory bowel disease, nephrotic syndrome, sepsis, thrombophilia, circulatory stasis, or we call stasis, atrial fibrillation, left ventricular dysfunction, immobility, varicose vein, venous insufficiency, venous obstruction, obesity, pregnancy, and endothelial injury like venipuncture, chemical irritation by IV fluids, injections, traumatic injury, heart valve replacement, valvular disease, atherosclerosis very rarely, indwelling catheters, pacemaker wires, central venous catheters, etc. So you can say genetic causes, some of the genetic causes, that is factor V deficiency, anticoagulant deficiency, prothrombin. Among acquired, age, previous venous thromboembolism, cancer, obesity, varicose vein, oral contraceptive pills, these are acquired risk factors. Triggering factor can be pregnancy, surgery, immobilization, trauma, air travel, etc. This is a big list. These are medical patients, these are surgical patients, and these are venous thromboembolism risk factors. Almost we have uttered majority of those. So all these causes can become a risk factor for thrombosis, venous thrombosis, and thromboembolism. At your leisure time, you can go through. We already mentioned immobility, trauma, surgery, infection, postpartum period, obesity, pregnancy, oral contraceptive pills, inflammation, postoperative period, heart failure, hypotension, IBD, sepsis, myocardial infarction, other risk factors like malignancy, age, previous venous thromboembolism, varicose vein, dehydration, oral contraceptive pills or hormone replacement therapy, etc. All this can be responsible. These are low risk, moderate risk, high risk, and highest risk. You can go through your at leisure time. Now what happens? Whenever there is a venous thrombosis, there is an occlusion of deep vein. So there is a venous congestion. It can lead to venous edema. Secondary to venous edema, ischemia, ulceration, and it can end up with venous gangrene. And secondary to infection, in that obstructed vein, you can get flemmexia caerulea dolens or painful blue inflammation. And if there is an acute arterial occlusion along with that, it can give rise to flemmexia alba dolens. This is blue, this is pale. And venous thrombosis can end up with venous thromboembolism, pulmonary embolism, and that pulmonary embolism can end up into acute cor pulmonale, and which will be RVH with congestive heart failure. Also, varicose vein can form venous thrombosis and thromboembolism leading to pulmonary embolism. Venous congestion, ischemia, and ulcer formations. So, three conditions: vessel wall injury, stasis, hypercoagulation, whether inherited or an acquired conditions, they can end up into venous thrombosis. So thrombosis can be secondary due to endothelial injury, platelet activation, coagulative system activation, hypercoagulation, and because of stasis. Mainly the vein of calf muscles are most commonly involved. We call as a great saphenous vein, and then it can extend proximally, involving popliteal, femoral, and then iliacs. And it can even involve inferior vena cava. So most common involvement is of calf muscle, then it can extend into popliteal, femoral, iliacs, then can extend into IVC. This will be the common, this is normal blood flow, this is a deep vein thrombosis, and this is showing you thromboembolism, dislodgement of a part of a thrombus. And from there it will go to IVC and right atrium, RV, and pulmonary artery, and giving rise to pulmonary embolism. Because of occlusion, increase in venous pressure, decrease venous drainage, dilated tortuous vein, we call as a varicose vein. Classical varicose vein, which will be dilatation of superficial venous system, and this is secondary to venous thrombosis. You can have edema and ischemic changes. Here there is a varicose vein, may or may not be because of deep vein thrombosis, but this is definitely in favor of deep vein thrombosis because there is edema plus inflammation. Now this deep vein thrombosis can recanalize. It can give rise to valvular incompetence, incompetent of perforated vein system, and then it will give rise to what we call as varicose vein. Pressure will be transmitted to superficial vein, varicose vein, release of free radical system, and that can give rise to ischemic damage and ulceration formation. And this is how the venous thrombus can dislodge, go to right atrium, RV and pulmonary artery and give rise to pulmonary embolism. Venous thromboembolism can end up with pulmonary embolism, pulmonary hypertension. Person can, because of massive embolus, can even get death. And small multiple emboli can give rise to chronic pulmonary embolism. Locally, deep vein insufficiency, post-thrombotic syndrome, and you can get ulcer, ulcus curis, that is skin changes, typical. You can see this varicose vein and these are the changes in the skin. So, because of major pulmonary embolism, you will have an obstruction and neurohormonal system will be working. So, there will be pressure load which will give rise to RV decompensation, increased RV volume, septal shift, pericardial restriction, decreased LV distensibility, decreased LV preload. Now, because of this decreased LV preload, decreased cardiac output, fall in mean arterial pressure, and that will give rise to decreased RV that can produce ischemia, increased RV volume can also produce ischemia. There will be increased demand, increased wall tension, but decreased blood supply. And secondary to ischemia, it can give rise to RV decompensation. Also, because of pressure overload, there will be ischemia and decreased RV cardiac output. Because of decreased cardiac RV output, there will be decreased LV preload. All this is a vicious cycle in case of pulmonary embolism. We already discussed in detail in separate video on pulmonary embolism. As far as clinical features is concerned, you will come across what we call as, you can remember this way, this will be trauma, oral contraceptive pills, road traffic accidents, operations, cholecystectomy, malignancy, blood disorders like polycythemia, obesity, old age, major surgery on hip or we call thigh bones, serious illness or sepsis, immobilization, splenectomy. This will be all predisposing factors. What you can see locally, leg swelling, leg pains which increase with walking or standing, visible superficial venous system in the form of a varicose vein, warmness and redness if there is thrombophlebitis, superficial thrombophlebitis, and person will also complain of fatigue. By and large, it is unilateral. You will have a leg cramps, leg pains, skin will be warm, there may be erythema. If there is a thrombophlebitis, fever, tenderness on palpation will be very common, particularly in a deep vein thrombosis. So swelling, redness, elevated local temperature and tenderness is the most common. 95% of the patient of which symptom, it is very easy to diagnose a deep vein thrombosis. In 50 to 85% of the patient may be asymptomatic. Homan sign is quite commonly positive, where you get pain on dorsiflexion at ankle, but it is not 100% confirmatory test. because there is a no 100% sensitivity or specificity. If there is an inferior vena cava involvement along with the deep vein thrombosis, then lower limb will be edematous and cyanotic. If there is a superior vena cava involvement, then you will have a edema of upper extremities, neck, face, etc. And you will have a dilated veins over the shoulder and over the chest, extending into the abdominal region. And the blood flow will be from above downwards in case of superior vena cava. And in case of IVC obstruction, it will be from below upwards. So the most common is pain, tenderness in the calf muscle region, swelling. By and large, it is unilateral. You can have redness, warmness, edema, cyanosis, and Homan's signs will be positive. So this is a typical Homan's sign will be positive, but while performing this test, you should see that you don't end up with pulmonary embolism because of repeated calf muscle compressions. Thrombus can dislodge and give rise to thromboembolism. So do look for that. In case of acute and chronic, what is the difference? That has been shown here. In acute, there is a loss of compressibility, echolucency, while in case of a chronic, there is increased echolucency. In acute, there is lack of collateral vessels, while there is in a chronic, usually collaterals will be dilated and tortuous. Venous distension will be quite common in acute, but in case of chronic, shrunken fibrous cord-like venous system will be seen without inflammation, while there will be surrounding inflammation will be very frequently present. We already mentioned that good number of people will be asymptomatic, and when they are symptomatic, pain, swelling, varicose vein, and because of chronicity, they can end up with lipodermatosclerosis with or without venous ulceration. You will have a Homan sign positive, Mosses sign positive, and it can end up into phlegmasia cerulea dolens, where it will be blue color with collateral vessels are occluded, while phlegmasia alba dolens will be associated with paleness, which is because of involvement of arterial system, because of arterial involvement. Mosses sign is tenderness over the calf muscle, but while doing that, be careful, don't end up with thromboembolism. 80% of the case is iliofemoral vein involvement, popliteal vein involvement, calf muscle is in 30%, and inferior vena cava involvement is very rare. The most common involvement is a calf muscle venous system, which can extend into popliteal and then into iliofemoral. We already mentioned all this: tenderness, swelling, increased temperature, fever, superficial vein will be dilated. So we'll have edema, little amount of inflammation, tenderness, and with severe obstruction, you can have cyanosis also. And there are two conditions: phlegmasia alba dolens, which is along with involvement of the arterial system, and phlegmasia cerulea dolens will be bluish color. And then you can end up with venous gangrene. And one of the another complications is pulmonary embolism. We already mentioned all this. Depending upon those conditions, you can see the difference in the color. There is edema, change in the color. This will be warm, tender, erythematous. There will be swelling, we call edema, and it can end up into phlegmasia alba. And cyanosis is called phlegmasia cerulea dolens. And when there is a pulmonary embolism, you can have dyspnea, tachypnea, diaphoresis, hemoptysis, low-grade fever, pleuritic chest pain, cough, and if it is massive, it can end up with hypotension and person can even have coma. And you can diagnose by doing ECG, which will show you S1Q3 T3 pattern, plus right axis deviation, incomplete or complete right bundle branch block, or RVH type of QRS complex in V1 and AVR. Sometimes you can have atrial flutter fibrillation, etc. It will be low voltage with tachycardia. Are some of the ECG findings. In X-ray chest, you can have Western hump findings in plain X-ray chest, and you can confirm by doing pulmonary arteriography or pulmonary angiography. So in X-ray chest, you can have a Hampton's hump and Western green sign. So venous stasis, injury, hypercoagulation, thrombus formation, dislodgement of the portion of a thrombus, pulmonary embolism, which will give rise to hypoxic vasoconstriction, decreased surfactant, release in neurohormonal and inflammatory mediators, pulmonary edema, atelectasis, and secondary to that you will have a tachypnea, dyspnea, chest pain, increased dead space, VQ imbalance. So you can have, if you get a VQ scan, you can see that there is a VQ imbalance, decreased pulmonary arterial oxygenation, infarct, pulmonary hypertension, hypoxia, vasoconstriction, further pulmonary hypertension, decreased cardiac output, and that can end up with systemic hypotension and even shock stage. These are all the different signs which you can get in pulmonary embolism. I've discussed in detail in that. You can see some of the signs are not very common. The most common signs are dyspnea, pleuritic pain, cough. And you can have associated finding in a lower limb in the form of a leg swelling, leg pains, tenderness, warmness, etc. Among respiratory finding, tachypnea, crackles, tachycardia, fourth heart sound, etc. are seen in so many group of people. You can see that this is most common sign is dyspnea, pleuritic chest pain. That is most common. And cough hemoptysis is less. Tachycardia is quite common, and tachypnea is also common. If you want to confirm the diagnosis of pulmonary embolism, you can utilize two-level pulmonary embolism Wells score. And depending upon the points calculation, clinical symptom signs of DVT 3 points, and alternative diagnosis is less likely, that also gives 3 points. Tachycardia 1.5, surgery, immobilization for more than 3 days, surgery in previous 4 weeks, 1.5 point or 1.5. Previous DVT, previous pulmonary embolism, 1.5. Hemoptysis 1. Malignancy treated or on treatment in past 6 months, 1 point. And when you add up all those, if it is more than 4, then it is more in favor of pulmonary embolism, and if it is less than 4, it is less likely to be pulmonary embolism. Very simple, very easy, and you can easily utilize because good number of things are what we call as a clinical findings. So clinical finding, history and clinical finding will give you a good idea by using two-level pulmonary embolism score, or we call Wells score. So you come across, you can see edema, changes, tenderness, Homan sign. You can see this is cerulina dolens. You can compare with the opposite limb. Redness, swelling, on palpation there will be tenderness, skin changes will be there. You can see the difference. This is superficial thrombophlebitis. You can see the changes, and this can end up with venous gangrene. This is lipodermosclerosis, edema. This is phlegmasia alba dolens because of associated involvement of what we call as arterial involvement. And this is cerulina dolens, where you will have a reddish purple, giving rise to engorgement and obstruction, discoloration, this particularly. You can see the changes. Yeah. Blue color. You can see here. So this is cerulina dolens, ending into venous gangrene. You can see this is venous gangrene. Edema and bluish discoloration, venous gangrene. Venous ulcers, they are usually small size, oval ulcer, edge are sloping, painless, usually on medial malleolus or lateral malleolus. Medial malleolus is more common, and surrounding skin is pigmented. There will be lipodermatosclerosis, there will be hemosiderosis, and there will be varicose vein, quite common. Homan sign will be positive, Moses sign or called as a Pratt sign. Then there is a Bancroft sign, Lowell sign, Lowenberg sign. Forget about all this. Remember Homan signs and Moses sign. Two common, these two. This is on movement, that is dorsiflexion of ankle joint, and this is just palpation, squeezing. But while squeezing, see that you don't end up with pulmonary embolism. So if you are interested at leisure time, there are many other signs also. You can go through your at leisure time. That is Homan sign, Lowenberg, Ramirez, Lisker, Lowell, Mikale, Mehler, etc. Most common performed is Homan sign, and second is Moses or Pratt. There is something called as a post-phlebitic syndrome. This is a late complication of DVT which occurs after several years of acute event, where you will have a swelling, ulceration, chronic valvular incompetence, edema, and there will be elevated pressure in superficial venous system. There will be brownie induration from hemoglobin metabolism. That is why it is labeled as post-phlebitic syndrome. And there is another called as a post-thrombotic syndrome, where you will have a pain, edema, discoloration, varices, and ulceration. And it is following a long lag phase which can be in years. It is called post-thrombotic syndrome. Early catheter removal may reduce the chances of post-thrombotic syndrome, and thromboembolism stockings can also reduce those particular symptoms, and use of graduated compression sleeves can also reduce the incidence of post-thrombotic syndrome. And so these are the three treatments. Early catheter removal as soon as the purpose is done, stockings, and graduated compressive sleeves you can utilize to reduce the chance of post-thrombotic syndrome. This is how you approach in a person with DVT. If there is a high possibility, use directly Doppler ultrasound. If ultrasound is negative, then you can go for D-dimer studies. And if ultrasound is positive, diagnosis of DVT is confirmed. If there is a low possibility, then you can go for a D-dimer study. If D-dimer study is positive, then go for a deep ultrasound, or we call Doppler ultrasounds. And then on an ultrasound, if it is confirmed, you begin the treatment. If it is negative, you can wait for a while. So if D-dimer is negative, usually DVT is ruled out. And if D-dimer is positive, you can repeat an ultrasound again and then start with the treatment. So clinical suspicion, If it is low, go for D-dimer study. If it is high, go for a duplex ultrasound. Positive, start treatment. Negative, you can go for D-dimer test and again repeat duplex. So mainly what is being said is clinical history, good examination, and then you can go for duplex Doppler and D-dimer study. D-dimer study if there is a low possibility, and go directly for duplex ultrasound if there is a high possibility. So same thing shown in a different way. These are all different algorithms which you can go for. And in a person where you are suspecting pulmonary embolism, go for a well score. Well score is very, very important, and if well score is positive, then you can go for a D-dimer, and then you can go for a pulmonary angiography, CT pulmonary angiography, or you can go for a VQ scan, etc. So well score is very important. Ultrasonography to find out the possibility of deep vein thrombosis, contrast venography, D-dimer level will be helpful, but it can be false positive in many other conditions. Color duplex scan for deep venous thrombosis, and then you can go for pulmonary embolism investigations like X-ray chest where it will show West Green sign and Hampton's hum. You can go for pulmonary angiography with or without CT. ECG may be of some help, and you can also go for a cardiac biomarkers because invariably there will be increased right ventricular pressure leading to BNP elevation, and even N-terminal BNP will be also elevated. To find out the risk factors, antithrombin 3 deficiency, protein C, protein S deficiency, prothrombin, and factor 5 deficiency also. Factor 5 Leiden deficiency. Even homocysteine level, antiphospholipid syndromes, you can go for an antibody study in those groups. Invasive procedures are very rarely required like venography or radiolabel fibrogen study. By and large, the non-invasive study like ultrasound and color duplex will be very helpful. Plethysmography with or without MRI can be one of the conditions where it will be helpful. So ultrasonography with color duplex is very helpful. MRI CT scan is mainly when you are planning for some surgical intervention. So ultrasonography with color duplex is very helpful. So this is the most important study. It can detect where is the obstruction, how severe is the obstruction, etc. Venography to find out the different venous system involvement, particularly in IVC thrombosis and iliac veins. You can use either CT or MRI study. So CT or MRI is included. Venography, again I have told you that it will be very helpful if you are suspecting iliac's IVC obstructions involvement, etc. In those groups it will be helpful. So these are all the big list. Chest X-ray, these are all for pulmonary embolism. VQ scan, spiral CT scan, pulmonary angiography with MRI or with CT, echocardiography. As far as laboratory, D-dimer, ABG study, CBC and ESR does not give you much idea. Ancillary tests like ECG may be helpful, pulse oximetry may be helpful. So this is all that big list which you can go in a pulmonary embolism: ABG, BNP, troponin, D-dimer, EKG, chest X-ray, ultrasound, VQ, and CT pulmonary angio or MRI pulmonary angio, etc. You can see here this is called Westmark sign, which will be there, where you get oligemia of right lower limb, occlusion of a large lobar or segmental artery, you will have atelectasis. Hampton's hum will be seen in a periphery which indicates lung infarct, Hampton sum, and this is called Weismach sign. Weismach sign means you will see a pulmonary vessels and there will be suddenly oligemia, widespread oligemia because of occlusion. It will be seen in 5% of the people. Atelectasis is almost in 68% of the people. Hampton sum you can see in good number of people. You will have a dilated pulmonary artery in 15%. This is typical ECG changes we call S1, deep S wave in lead 1, Q wave and T wave inversion. That's why we call S1, Q3, T3 pattern. Right axis deviation, incomplete right bundle branch block or right bundle branch block, tachycardia, etc. are common finding. You can have a low voltage, flip T wave. Good number of time it is described as a flip T wave in lead 3. So T wave is flipped. That is very common in lead 3. So these are some of the findings which you can come across. As far as prevention is concerned, you can use low molecular weight heparin. Pharmacological therapy in a deep vein thrombosis, you can go for thrombolysis by using thrombolytic drugs. For prevention, you can go for anticoagulation, which can be oral or injectable, or you can use a newer anticoagulant we call NOAC. In a person whom you suspect a very high risk group, you can go for a combination of thrombolysis with mechanical. So you can start with thrombolysis and followed by mechanical, or you can start with both combined together, mechanico-chemical or chemico-mechanical. And when it is a massive, you might have to go for surgical intervention like thrombectomy, and then in a high risk group, you can go for a IVC filter. Bed rest, gentle food and leg exercise, adequate fluid intake, avoid deep palpation. You can start with prophylaxis against DVT and treatment for DVT if there is already established DVT. You can use anticoagulation, thrombolytic therapy, surgical intervention, filter, compression stocking, etc. depending upon how severe the disease is. In prophylaxis, identify the person who are at risk and severity of risk like mild, moderate and severe. Prevent dehydration. During operation, avoid prolonged calf compression. Leg exercise should be encouraged. Foot of the bed should be elevated. Early mobilization should be advised. Low molecular weight heparin, oral anticoagulants. You can use dextran, you can give antiplatelet therapy, maybe single or maybe dual antiplatelet. Mechanical compression, early ambulation is helpful, and low molecular weight heparin or unfractionated heparin can be utilized as a prophylaxis and during treatment. These are different type of stockings which are available. You can utilize those with or without anticoagulation. Early mobilization is very, very helpful to prevent. This is compressive stockings which you can utilize, which will be very, very helpful. So antithrombotic treatment, thrombolysis, IVC filter, thrombectomy, and as far as antithrombotic treatment, unfractionated heparin, oral anticoagulants, low molecular weight heparin. You can use any one of low molecular weight heparin, oral anticoagulants, or unfractionated heparin. That will be as far as prevention of thrombosis is concerned. Prophylactic treatment or once already the person has got. And very important is in a person with phlegmasia, you can go for thrombolysis, and in a person with a high risk group, you can have a IVC filter, and sometimes you might require even a thromboembolectomy, or we call thrombectomy. So venous thromboembolism, you can go for heparin, oral anticoagulant, low molecular weight heparin, thrombolytic therapy, etc. So you try to find out risk groups, and depending upon that you can decide. These are all the different flow charts which you can go through. This is anticoagulation with IVC filter, anticoagulation, IVC filter, thrombolysis, embolectomy, etc. And you can go for anticoagulation, IVC filter depending upon indication, contraindication. This is another flow charts. This is another flow chart. Depending upon what stage, what are the risk factors, you can go through. So these are side effects of heparin. These are side effects of oral anticoagulants. You have to keep that thing in mind. These are stockings. This is IVC filter to prevent thromboembolism. It is described as a greenfield filter inserted into IVC, inferior vena cava. This is thrombectomy. You can see how big the clot is. So IVC filter, these are different types of IVC filter which are available. You can use those IVC filter. You can see this is IVC filter. So you can prevent thromboembolism. This is pulmonary embolism, heparin, low molecular weight heparin you can use in a high risk submassive. You can go for catheter directed lysis, or we call chemolysis. And in a massive pulmonary embolism, you can go for catheter directed chemolysis, or what we call thrombolysis, or you can go for surgical embolectomy, etc., depending upon what stage it is. This is pulmonary endarterectomy. You can see how big the size of clot which has been removed, or what we call thrombus which has been removed. This is in superior vena cava syndrome. I'm skipping over that. You can treat those varicose vein by what we call as a laser therapy, or by sclerotherapy, etc. Complications, most common complication is pulmonary embolism, non-healing ulcer, infection, gangrene, which is a very common following phlegmatia cerulea dolens, and because of arterial spasm it can give rise to alba dolens, chronic venous insufficiency, hemorrhagic complications, recurrent DVT, varicose vein, post-thrombotic syndrome, post-phlebitic syndrome. It can go ascend upwards to involve iliacs, inferior vena cava, and you can get even a renal vein thrombosis. Sudden cardiac death, very commonly because of massive pulmonary embolism, shock stage, pulseless electrical activity, ventricular arrhythmias, atrial arrhythmias, particularly atrial flutter fibrillations are quite common. Secondary pulmonary arterial hypertension, cor pulmonale, severe hypoxia, right to left intracardiac shunts, pulmonary infarcts. In post-thrombotic, varicose vein, abnormal pigmentation, venous ulceration, quite common. Varicose vein, this is pigmentation, and this is venous ulcer. And you can see this varicose vein, pigmentation, and ulcer. Conclusion: DVT is a silent killer. Pulmonary embolism is the most common and dangerous complications. Equal incidence in medical and surgical sites. Prophylaxis is the only way out. Heparin, low molecular weight heparins, and other effective therapies should be started as early as possible. Early mobilization is the best. Pneumatic devices also we call sequential compressive therapy will be very helpful. So I end my lecture here. I hope this lecture will be helpful to you. You will see good number of times this group of people in your everyday practice. If you diagnose them early, you can prevent complications and high mortality.